The two queens. Yeah. Somebody asked me before Wonderland, they said, do you think the stage can handle this much awesomeness? Because they heard that Julia Mirer was going to be with me. And I said, we're just going to have to see. I don't know. Would you like to introduce yourself?
Sure. My name is Julia Mirer. I'm a recovering physician. I left medicine back in 2018. I discovered the psychedelic space haphazardly and then very intentionally got involved from many sides, from the research to the funding to the clinics. And for me, that's allowed me to see a lot of the blind spots that we have, especially because a lot of these different areas in policy too, they're in silos. And so we're missing a lot of things, and I get to see kind of where can we make adjustments so that we could roll this out in a responsible and ethical way.
Yes, ethics, thanks. And I can't believe I've known you these many years, and you pronounce your name not the way that I do.
Dr. Mirer.
Are you sure it's right? I felt comfortable with my pronunciation. Okay.
Introduce yourself.
My name is Julie Holland. I'm a psychiatrist and author, and I've been happily involved in the psychedelic community and a member in good standing since the mid-'80s, which is a long time now. And I got in touch with Wonderland, and they gave me a few choices of what I could speak about, and I grabbed this one because it's a juicy topic. We need to talk about informed consent and ethics as much as we possibly can. Luckily, we have 22 minutes and 22 seconds, which is, it's a complex topic, but I think we can pretty much wrap it up then.
Actually, I think that you could wrap it up in one sentence.
Oh, it's so funny that you mentioned that, Julia. I'm having this memory. Was it 2 years ago? We were at a Wonderland conference, and I had about 5 minutes to make my point. And right at the end, I really said that the bottom line, people, if you're talking about ethics, is don't fuck your clients. And then I dropped the microphone, quite literally, and walked off the stage. So I think that's a great place, a good jumping off point, right? Can we at least agree that either you're going to be in a sexual relationship with someone, or you're going to be in a working relationship with someone, and those two things, while it may be very therapeutic for you to be in a sexual relationship, you can't be sexual in a therapeutic relationship. Sorry. Very easy. One of the reasons why I picked this informed consent topic also is that, to me, it's just the most basic building block of harm reduction is education. And informed consent is all about educating the client. What is likely to happen? What are the risks of what you're doing? What are the benefits of what you're going to do? What are the alternatives if this isn't your choice? And in medicine, discussing risk-benefit alternative, which is standard informed consent, it's pretty easy. If you're consenting somebody for surgery, it's really only a handful of things. Either the surgery is going to go great. Hi, Lauren Schwartz. Hope you're out there. Or maybe if it's neurosurgery, there's a risk of you having a stroke, or a heart attack, or a seizure, or your seizures may stop, or your seizures may never stop, or you may die. Maybe there's 5 or 6 things, and you hope there's a good outcome. But if it's a bad outcome, it's still a handful of possibilities. You go over all of them with the patient, they agree, they explain back to you, so you know they really got it, and they sign the papers, and you're done. And would you like to discuss how it's different when it's psychedelics?
So how do you inform somebody about a place that you don't know where they're going to go? So you can do the best that you can, and you could do, they have VR. It's like, this is what it might look like with all the colors and stuff, but you don't know. You don't know what's in their deep psyche. You don't know what traumas maybe there's some that they told you about, and you're like, oh, you might relive these moments. But there's probably some, very likely, there's some that they don't even remember. So how do you prepare somebody for remembering something that they have no idea is about to come up? And then also, I think the good point that you made is that's just for the dosing day. So yes, you can tell them you may see nothing, you may see a lot of things, you may see past experiences, you may see experiences that weren't actually your past, but then what happens after?
Right. So in medicine, if you're consenting for a procedure, it's just the procedure. It's not what's going to happen in the days or months after the procedure. And these are disruptors. Psychedelic medicine is a disruptive field, and I know we love the term disruptor, but this really is a disruptive, transformative experience that's going to happen. So it's not just consenting for that day. It's like you might discover things that make it impossible for you to go back to your life. You might discover things about yourself that make it impossible for you to continue in a relationship, in a job. How do you consent people for what comes after the treatment?
I had no such consent talk, and I resigned 3 months later. So now I sit here telling people, like, you don't have to do that. Think about it. Leave in a more graceful way if you're going to leave. But yeah, this is something, because it becomes intolerable to exist in the systems or the relationships or whatever you were living in before.
One of the things that psychedelics really reliably do is that they give you fresh eyes and a fresh perspective. And they reliably disrupt habits. So if your habits have stopped and your perspective have changed, it's possible that your values are changing. And one of the things that you do with informed consent is that you try to have this values-aligned decision-making, where you have enough communication with the client about what's important to them, what they want, what they don't want, what are the decisions, what are your values. And so, but the problem is, what if your values change? What if the you who consented, you're really consenting, like the present you is setting up the guidelines and the boundaries for the future you. Informed consent is like a collaborative process. It's not just the practitioner. It's really two people talking together about what's important, what you want, what you don't want. And touch. Obviously, you have to navigate touch ahead of time. Right now, when you haven't taken MDMA, how would you feel about me putting my hand on your shoulder, on your knee, on your head, on your heart, on your hand? Are you okay with that? Do you want a foot rub? I think it's safe to say there's not much of a reason to be touching between the knees and the chest. You can have a therapeutic touch on lots of other parts that aren't very sexual. I mean, I get some people have foot issues. It's okay. But in general, the person ahead, you decide ahead of time what the rules are going to be. And then the issue is what happens during the session if you want to change the rules. And it's usually, one way that you could do it is like a hard no, a soft no, and a yes. Like, I absolutely don't want you touching from here to here under no circumstances. Maybe I'm okay with you putting your hand on my hand. I'm going to have to see how I feel. Let's say that that's a soft no, and I can change it to a yes. But the hard no's don't change. You can always change a yes to a no. But it's a little trickier if you're saying ahead of time, like, I don't want to be held, and then you're tripping and you're like, hold me. And it's really hard for that person who said, we consented that I wasn't going to hold you. And if you're saying you really want to be held, I'm sorry, but that was a hard no. So we're going to have to save that for next time.
So there's actually, so in the clinical trial, we used psilocybin for major depression. And we had this conversation. Do you want touch? Some people were like, definitely no. And then some people are like, yes. Now, we had 2 white therapists, and we had a black woman. And so she consented. And the question is, what if at some point she's going through something that changes that dynamic? And all of a sudden it doesn't feel good to have a hand held in that moment. And so I think that's another thing that we need to bring into the conversation of, the depth of the things that can come up.
Yeah. The other thing is if you're consenting somebody ahead of time and you're talking about the risks and the benefits and the alternatives, if that person is delusional about the possible outcomes, if they've been fed a lot of hype about how great it's going to be, it's really up to us to... One of the things of informed consent is that you assess their understanding of the situation, right? And when I was a psychiatrist at the VA, I was really interested in ethics and informed consent, and I was on the ethics board with other people. And as a psychiatrist, I'm always looking for delusion, right? If you're delusional, if you need an amputation, but you think that there's some like delusional concept, like you can't cut off my foot because that's where I receive messages from the spirits or something. And sorry if that's offending anyone. I'm back to feet. So if this person is delusional about what the procedure is, what the risks are, what the benefits are. One of the things you do with informed consent is you assess the person's understanding. So I think this issue of hype and expectancy bias, it ends up really having an impact on informed consent that I'm not sure we're really thinking about.
So the flip side of that is when I think, as physicians, we take an oath, do no harm. And so when you have somebody coming in with treatment-resistant depression and they're like, this is going to save my life or nothing, or this is the end of the line, it's really important to let them know that, hey, after the psychedelic experience is when you may have the benefits, because otherwise they might leave this saying, it didn't help me, that's it, I'm broken. So have you actually made them better or have you caused harm?
Yeah, boundary violations, speaking of causing harm, I think many of us can sort of understand how boundary violations happen. I think it's important to acknowledge that there's a lot of narcissism and a lot of ego at play with boundary violations. I think it's okay to also acknowledge that there's some adrenaline-seeking kind of junkie behavior that, you're doing something that you're not supposed to do and you may have to hide it. And there are plenty of people in the helping profession, a present company excluded, who are like a little bit adrenaline-seeking, novelty-seeking. It's hard to know where to even start to talk about this. And whenever I start talking about boundary violations, I always say the same thing, which is, we need a conference about this. This is a thing. It's one of the biggest risks. It's obviously cropped up in the underground community. There have been a lot of boundary violations. We've had egregious sexual violations and boundary violations in the research community. So we've got them underground, we've got them in research, we've got them in, the truth is that there are terrible boundary violations that happen in the dentist's office, in your therapist's office, with other psychiatrists. It's not just confined to psychedelics. I think we all know that, sort of intuitively, but it's kind of like that on steroids. As much as there is a risk of boundary violations in intimate therapeutic settings, it's safe to say that when you add in MDMA or ketamine or other psychedelics, that you're increasing the risk, you're increasing the intensity. There's this, what was the intimacy word? I wrote, a risk of all psychotherapy, not unique to psychedelics, but possibly more likely due to, and then I put in quotes, intimacy. And I know that's something you want to talk about, is this sort of shared space between the practitioner and the client.
There was a course on ethical right relationship with clients, and it gave an example actually of breath work, which can also lead to these altered states. So it was a therapist that was doing breath work with a client, and they just meet in the other world, and they're like, oh my God, we must belong together. They go through a relationship, eventually they decide, the client decides they don't want this, and she loses her license because it became a whole thing. And so to me, I think there's another part of this where therapists are also, for the first time, experiencing being around somebody in this altered state, in this non-ordinary state of consciousness. There's this kind of connection that can happen, and it can be intoxicating for some. And so it becomes really important to do your own work. And I would even suggest that it's important, ethically, we need to make this part of every training program. And until you've proven that you've addressed a lot of your kind of biases and your trauma around feeling helpless, I think all of these have to be assessed in some way before you're allowed to sit with clients, because then there's boundary violations that are physical, but then there's also you guiding somebody towards where you want them to go, or you investing in them when they're not asking for help in an area.
There's two things that come up for me. One is this idea of having sort of a rescue fantasy or a hero fantasy that, you want to be the one person who could help this person that nobody else could help. But also this discomfort when someone is in need and not being able to just sit with your own discomfort that somebody else is in discomfort.
The gaps in the traditional ethics, this is from that course, it said, traditionally we look at the behaviors and controlling the actions of therapists. We're not helping therapists understand their inner motivations. And when somebody is helping, some people, again, their own version, but there's the healing impulse, and every ethical misstep has a healing impulse. But why are you helping? Is it because this person needs help, or is it because you are uncomfortable with their discomfort?
Word. Yeah, I think that's really important. A lot of us, obviously, we want to help, we want to do good, and, some people are more controlling or manipulative than others. And anybody who's ingested psychedelics is in a really highly suggestible state. And you need to step very carefully, or just shut up. There was this guy sitting down earlier today, and I went over to talk to him, and he was sitting like this.
Yes.
And I went up to him and I said, "Are you ready? Are you holding space?" So when we hold space for somebody, sometimes it's enough to just sit and bear witness to their pain and their sobbing. And just because they're sobbing and in pain does not mean that you need to hold them, comfort them, anything else. Sometimes it's okay to just bear witness. And sometimes that's all people need. They just need to be seen and heard.
And so then it becomes really important for you to know how you react when somebody's uncomfortable. Because if your nervous system starts to get activated, then the role that you can potentially play for this person that's sitting in front of you is this like regulated nervous system that they can attune to, you can no longer play that role. So again, and one of the things that we talk about even in the clinic, it's like, okay, before you go in there, breathe. Check in with like 2 sensations in your body and a feeling. Because if you're not okay going in, it's going to be much harder to handle somebody who's not okay in that moment.
Yeah, I mean, it's a lot like picking up a baby, right? If a baby's crying, the first best thing you can do is to calm yourself and be calm before you pick up the baby, because then the baby feels how calm you are. So if you're guiding somebody and they're struggling and you start freaking out because they're struggling, you're co-regulating each other into sympathetic instead of parasympathetic. I have two rules in life, really. And the first one is to never give out all the information. But that's not what informed consent is about. I just think that joke it's just so clever. A couple other things I want to talk about because, and also, we're not going to talk about the ethics of doing informed consent for research. We thought we would just stick with treatment, but there's a whole different set of rules surrounding informed consent with research. And I actually gave an hour-long, incredibly entertaining talk with pictures, courtesy of Jeremy Wolf, my partner. And if you just Google Julie Holland ethics, you'll see lots of stuff about clinical research. So that's why we're really just focusing on treatment and therapy. And the bottom line, and I know Julia feels this way too, is that we really just want to strengthen public mental health infrastructure and access. Access and equity is really the ultimate goal. And I know we have a really long way to go in sort of decolonizing this space. And honestly, like decolonizing the entire hierarchy of medicine. And again, we could spend a long time talking about that. I don't know if we want to do Q&A. Look, I usually love Q&A and want to do like an hour of Q&A. I'm a little worried about opening up a discussion about ethics and informed consent to Q&A because there is no, it's 50 shades of gray. There's nothing cut and dry. And it's gonna be really frustrating if people have like horrible stories that they want to share. So we know they're out there.
So, and I'll touch on something that you said with just how, so to me, psychedelics, okay, they bring light to the shadows within us, but they also bring light to the shadows within our systems. And so every system that psychedelics touch, whether it's policy, mental health care delivery, drug development, it's showing us like, something's not right here. And so to me, I think in terms of ethics, like when we look at, okay, insurance coverage, are you insurance covering, like is the insurance covering the medicine? Or is it going to cover all of the therapeutic container that is necessary for this medicine to be effective? Because we've played that game where insurance covers your SSRI. How did that work out? And so if you plug something that works into a system that is broken, it's only a matter of time until it's going to collapse. And then the other thing is, again, going back to doing your own work, if you're going to be working with these medicines, is We talk about the delivery mechanism. Pharma loves to talk about intramuscular, IV, oral. The delivery mechanism of psychiatric medications is the therapist. So the same way that a great therapist can make an SSRI work, you can have a really biased and toxic therapist make a psychedelic not work.
I think some of this can be sort of scaled, like, a big part of MDMA therapy or psilocybin, I think MDMA therapy in particular, right, that there's a lot of talking. And, in the studies, we had a lot of sessions, like preparatory sessions, before the drug-assisted therapy session. And in those preparatory sessions is all the getting to know you, where's the trauma, where do we think we might want to go, and some of the preparatory sessions can definitely be done in a group setting. Like maybe the therapy itself can't be done in a group setting, but teaching people about the basics of what's going to happen and how it's going to go and how long it'll take and how you'll feel after and just the very generalized things can definitely be done in a group. And I think that's going to end up happening more and more because it is going to get pricey to pay therapists for their time.
And also, when somebody works with a therapist, they're like the one-on-one relationship, like, oh yeah, my therapist loves me, of course, like they care about me and all of that. But that doesn't necessarily help them translate to the rest of the world, where there's other people that could see them in their yuck. There's other people that can witness them. So it might be that it even helps people just facilitate the healing process when you have multiple people in the world, not just this one therapist.
Right. Well, the other thing about going through with a group process where you have the group prep is that now you have peer support all the way through the process, which is sort of invaluable.
Especially because, the loneliness epidemic, we keep hearing about this, but there's a lot of value in just the two people from a group of 15 that you connect with, you can talk to about a shared experience without paying them, without having to schedule a time with them.
So there's a couple, just to wrap up, there's a couple real danger points when people are sort of preparing for their psychedelic experiences. For me as a psychiatrist, the number one danger point is when people are trying to get off their meds before the experience. It's hard to get off psych meds. There are some psych meds that are harder than others, but they're all pretty hard. You really have to do a taper. You have to work with somebody. You can't do it alone. Which means you really have to be honest with your psychiatrist or your PCP or your GYN. Why are you tapering? So a lot of people end up sort of going off meds in haphazard ways, and then they're in a really vulnerable state because they're off meds and they're in withdrawal. Then they're having an intense psychedelic experience and they're uncovering trauma. And then what? Now they're off meds, uncovering trauma. And that's why everybody all the time is talking about integration. It's this part. What happens after the session when you've got big feelings, big discoveries, but you're supposed to go back to your little life in a box and you're off your meds. So that's got to be part of informed consent. And I honestly think what's going to end up happening as time goes on is that we're going to realize that people don't have to get off all the meds they're getting off, and that probably it's better to stay on the meds. But that, again, a story for another time.
And
final thoughts? Julia, Mirer? Are you sure?
Yes,
Mirer, are you sure?
I think so. I'll double check. So when we talk to people about, I think other people have mentioned this, you have this big expansion with psychedelics, and then there's the contraction. And sometimes people feel like they are worse. Sometimes they are. But sometimes just returning to where your baseline was could feel like such a big delta. So it's kind of letting people know, hey, you've gotten used to living at this low level. So some days you're a little bit better, some days you're a little worse, it's like a small change. But now you have this big change, and to not be disappointed that, oh no, no, you're just become aware of what your current state is, and now you have the activation energy to make changes to change that baseline state.
Ding, 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 7, 8, wait, oh, it's going forward. I'm like, the numbers were going down and now they're getting bigger.
Time isn't real.
Thanks everybody for coming and for your attention. Thanks Wonderland for throwing this. Thank you, Julia.
Congratulate the two queens.